of the most expanding or exciting fields in clinical medicine or even research is the role of microbiome and its interaction with various systems, being the gut, the fat, or the kidney. So the gut interacts with the kidney and is supposed to be one of the major factors triggering its worsening of renal dysfunction. And probiotics and prebiotics assist in a way, or it renders the effect on the microbiome to or retard the progression of chronic disease. And in the next 25 minutes or so, we will see how its effects are, or how it works on the gut. So the healthy microbiome, the gut microbiome is the metabolically active organ. It contains almost 1 trillion microorganisms, thousands of different species, 3 million genes being encoded, and the human genome pales in comparison, which the human genome is only 23K genes. It acts as a complex bioreactor influencing the systemic, immune, and metabolic status. So, which are the major phyla? So, almost 90% is by firmicutes and bacteroids, of the 5 phyla. The rest is actinobacteria, verchomicrobia, and proteobacteria. This dominant phylum is basically firmicutes and bacteroids, the normal gut microbe. So of which the Akkermansia muciniphila is considered the gatekeeper of the intestinal mucosa, and the core functions include which synthesizes vitamins, that degrades indigestible plant polysaccharides. It maintains the epithelial barrier integrity, which is of most importance in nerve purview, and inhibits the pathogenic bacteria colonization. And the optimal microbiome output is one of the functions is short chain fatty acid synthesis. It maintains the intestinal tight junction proteins as well as many of the proteins, Xintacan, which plays a critical role in maintaining the intestinal tight junction, and in immunity as well, the induction of Tregs and suppression of NF-kappa beta pathways, of which special importance is for short chain fatty acids. The acetate, propionate, and butyrate. Acetate is implicated in systemic metabolic signaling. Propionate is a gluconeogenesis regulator, and butyrate is a primary fuel for colonocytes, and it enhances, not only does it do that, so it enhances the expression of ZO1 and ocludin, and it acts as a critical anti-inflammatory signaling molecule central to maintaining the gut integrity. As we all know, CKD is a state of chronic inflammation. It raises markers with IL-6 and TNF-alpha, persistently raised higher sensitivity CRP. Of course, immune cell activation, oxidative dysregulation, and electrical dysfunction is part and parcel of CKD, which leads to accelerated fibrosis and rather a decline in GFR. And as it progresses, this smoldering inflammations become both a driver as well as a consequence of the metabolic complications of CKD. So where does the gut stand here? This is one of the axes that underlines the importance of the gut. So the uremic milieu, the retained urea diffuses into the gut. The bacterial urease hydrolyzes it and raises the luminal pH. And this causes a microbial shift, especially the alkaline environment drastically alters the microflora that accelerates the production of so-called protein-bound uremic toxins, especially the precursyl sulfate and indoxyl sulfate, and that escape by the compromised gut barrier, directly driving the renal fibrosis, cardiovascular calcification, and accelerated CKD progression. It's not only kidney, but also the heart or the lipus fat tissue is implicated here. This is one of the just examples of how it is connected with the heart. So in OSA episodes, it creates transient hypoxia, which causes a microbial shift again in the gut microbiome, depleting the butyrate producers and multiplying lactate producers and disrupting the SCFA signaling and driving OSA-induced associated hypertension. This is again how the changes in the gut microbiome affects. So here the normal abundant Akkermansia muciniphila gets depleted in an obese profile and reduces the optimal short chain fatty acid production, which normally it stimulates the L cells to release GLP-1 and PYY. So, but in an obese profile, there is because this altered microbiome alters the ghrelin levels and insulin resistance, especially driven by systemic lipopolysaccharide translocation. So, what is the transition that happens in CKD? So this is again one of the studies, many studies have been done, especially by Vasari. So the pre-dialysis CKD from the profile of the Enterobacteriaceae, Enterococci, Lactobacillus, and Luminococcaceae increase, while Lactobacilliaceae, Prevotaliaceae, and Bacteroideaceae decreases, especially again Bifidobacterium also decreases. While hemodialysis, while Lactobacillus and Prevotaliaceae decreases, which is normally seen by the Proteobacteria, Actinobacteria, and other firmicutes increases. Beta-maltodiol is again the proteobacteria increase while lactobacteria and firmicutes decreases. This again combined from many studies together in CKD. So there is a bi-directional organ relationship. Which comes first, which is difficult to tell. Is the GI tract to the kidney gets affected first. So it's not an isolated organ failure, as we know. It's a systemic cascade, tightly governed by the axis. So as the kidney function declines, retained uremic toxins are secreted in the gut. It alters the intestinal microecology and creates a feedback loop that again accelerates renal decline. That's a vicious cycle that runs. The uremic toxins, endotoxins, cytokines damage the kidney, resize the urea, and impairs filtration again has the deleterious or bad effect on the gut microbiome also. So how does it do that? Well, the uremic toxin is normally excreted by the kidneys. It is retained and excreted in the gut lumen in the CKD patient. The pH, being a balanced pH, gets changed to alkaline, driven by gut microbes, which hydrolyzes urea to ammonia. The high saccharolytic bacteria like bifidobacteria is changed to overgrowth of pathogenic putrefactive bacteria. The intact tight junctions, which acts as a barrier to all these chemicals and bacteria, is disrupted, leading to the leaky gut. We'll come to that. So what causes the leaky gut here? So that is a dietary environmental shift. There's a loss of saccharolytic bacteria, which triggers a proteolytic phenotype. So, and barrier degradation happens with the short chain fatty acid deficiency, weakens the tight junction proteins, as we can see, the occludin, claudin 1. And there is a as the gut barrier breaks down, there's a translocation of lipopolysaccharides into the systemic circulation, leads to metabolic endotoxemia, activating the NF-kappa beta inflammatory cascade. All these leading to fibrosis and decline in GFR. So there is another proposed event, or the experimentally proven, is that the loss of CDKN1. CDKN1 is a major component of glycocalyx. It plays a critical role in maintaining the epithelial barrier. So then as the the chrysal sulfate and all the uremic toxins downregulate CDKN1 and precrysal sulfate and endoxyl sulfate all damages CDKN1 shells of, and one of the ways which gut the stool CDKN1 can be assessed or analyzed to assess the integrity of the gut microbiome. So it downregulates again, cause a leaky gut syndrome. So what are the other factors that affect gut microbiome in CKD? One is the level of urea, the GI oxalate secretion, the decreased dietary fiber intake, the phosphobinder use and prolonged use of proton pump inhibitors, constipation, the GI uric acid secretion, and antibiotic use. All these can affect the gut microbiome. So how should we intervene, or what are the targets of intervention for dysbiosis? As we know that this can lead to a progression of chronic kidney disease, there is some way that it should intervene and get back the gut microbiome to normal. So one is modulate the gut microbiota, block the lipoprotein polysaccharide, attenuate inflammation, absorb the uremic toxins from the gut, and restricting the proteolytic fermentation in colon. There are many paradigms here. So one of them is intervention is a dietary framework, and for the Plado protocol. So see, the diet has a significant influence on the gut microbiome. As with a West animal-based diet, there is a low short-chain fatty acid yield, there is a high uremic toxin production, and it promotes proteolytic shift and dysbiosis. So the penetration of bacteria and uremic toxins are facilitated here, increased inflammation and oxidative stress, and they reduced gut motility. While in the other two dietary types, that is diet type of high fiber Mediterranean diet with increased short chain fatty acid yield, there's a low uremic toxin, there's a low uremic production or toxin production here, and is excellent for metabolic base and increases some of the treated good bacteria like bifidobacterium. While the Plado, so-called plant dominant low protein diet, with many trials or many papers are coming out now, there's a high short chain fatty acid yield and the lowest uremic toxin production, and is specifically designed for CKD with a low protein and more than 50% plant-based. Protects kidney function while minimize the hyperkalemia risk. So this again increases gut motility, it increases saccharolytic bacteria, decrease inflammation, acid load, increase SCFA, and decrease uremic toxins. So this is one of the paradigms here. The other dietary interventions. One is curd, contains lactobacillus streptococcus thermophilus, whereas advantages are natural, culturally acceptable, it improves bowel regularity. But the limitations, there's an unknown strain specificity. We don't know which is good or which is bad. Variable colony count, whether it's adequate. There is no RCT evidence here. And there is a relevant or increased potassium and phosphorus load here, which might preclude its use in advanced CKD. Fiber as a target is 25 to 30 grams per day, which is very less in our usual diet. It promotes saccharolytic fermentation, increases endogenous short chain fatty acid production, and significantly reduces indole formation. And the Plado diets correlate with lower toxin burden. The other intervention is either fermented dairy products, which provides Lactobacillus helveticus and generates specific peptides that reduces blood pressure. The high molecular weight beta glucans are seen in oats and barley and called increases bacteroidetes expansion, which increases short chain fatty acid supply. And resistant starch or inulin. Inulin is a component of many of the pre-probiotics combinations, which gives again gives supplements bifidobacteria and maximize the butyrate yield, that fortifies the tight junctions and altering neural food decision pathways. So the third one is what we're dealing with, this microbial therapeutic spectrum. This is prebiotics, probiotics, and symbiotics. Prebiotics are non-digestible ingredients that feed native commensals with slight but significant reductions in serum urea. Probiotics are live strains that Lactobacillus bifidobacterium, which supports the barrier integrity, reduces cholesterol, though colonization is often transient. We need to supplement often. Symbiotics is combining pre and probiotics. There is a higher abundances of beneficial strains and moderate BMI reduction here. And postbiotics, direct delivery of metabolic sodium butyrate. It bypasses fermentation to directly modulate immunity and inflammation. How probiotics help here? So it metabolizes toxins in the gut. So actively lower the uremic toxins by metabolizes them directly in the intestinal tract before they cross onto the systemic blood circulation. Secondly, it competes with the pathogenic bacteria for nutrients and addition sites on the intestinal lining. It suppresses the growth of the pathogens that produce these toxins. It strengthens the intestinal barrier, especially by increasing the abundance of short chain fatty acid producing bacteria, and lowers the intestinal pH. So it lowers the local pH in the intestinal lumen. So here's the role of, so there are a number of probiotic formulations, and many of the studies have come out of multi-species probiotic formulations or combinations. So of which one of the common combinations has been studies have been done is the combination of Streptococcus thermophilus, Lactobacillus acidophilus, and Bifidobacterium longum. So Streptococcus thermophilus acts to reduce the BUN, uric acid, and picrosol in the blood plasma, while Lactobacillus lowers the concentration of uremic toxins in the blood stream and specifically prevents pathogenic bacteria crossing onto from the small intestine and pathogenic bacteria growing in the small intestine. Bifidobacterium longum removes putrefactive bacteria as well as toxic phenolic and indole metabolites, helping to slow the progression of the disease. While Bacillus coagulans is a spore-forming nature, enhanced survivability, that is, it's ease of formulation. It can actually stay for a long time and it's a longer shelf life here and much more stable. And regular supplementation, many studies have shown significantly lower the bodily burden of dangerous uremic toxins like urea, indoxasulfate, and picrosyl sulfate. So, and go for studies on that. The synergy, there's a symbiotic seizing renal failure by improving gut microbiology trial, which used a combination of probiotics of Lactobacillus acidophilus bifidobacteria with a prebiotic inulin. Of 37 patients with severe CKD, 12 weeks or RCT showed it significantly reduced serum picrosyl sulfate, but no effect on indoxated sulfate. The antibiotic, the reduction were much more pronounced in subgroup of patients who did not receive antibiotics during the study period. And it favorably modified the stool microbiome of these patients, especially enriching beneficial bifidobacterium and depleting Rominococci. This is another study which showed both in dialysis and 3 to 4 CKD. So 28 CKD5 patients with a blend of 3 strains, that is Thermophilus, Lactobacillus acidophilus, and Bifidobacterium longum. No adverse effects with all 3 billion. There is a significant reduction in creatinine and C-reactive protein and reduction in urea, potassium, in overall quality of life. In pre-dialysis CKD, again, a comparative study showed more positive results of patients not yet on dialysis. It significantly improved GFR, reduced creatinine burn over 180 days, and significant decrease in picrosyl sulfate and 3-indoxyl sulfate. So another study published in Frontiers Nutrition by efficacy of probiotics with symbiotic supplementation in patients with CKD, which showed that supplements significantly reduced BUN and lowered CRP levels, and was found to be effective in improving renal function indices and inflammation indices. So subgroup analysis suggested long-term supplementation is more favorable for CKD patients, but there's a high degree of heterogeneity in partial subgroup analysis here. This is one of the latest studies. It's actually published this month, Kidney International. It's one of the largest cross-sectional study to date on gut microbiome and kidney health. So this study quantified the links between gut microbiota and EGFR in 2 population-based Swedish cohorts. So it used deep shotgun metagenomics. It is a high-resolution sequencing approach to study all the whole genetic material present in the gut microbiome or a microbial community was studied. So by using deep shotgun metagenomics, it profiled fecal samples from 2 cohorts. One is the so-called SCAPIS and the other, the MO is Malmo study. And by linear regression, related the relative abundance of metagenome assembled species to GFR and adjusted for other factors, demographics, albuminuria, cardiovascular risk factors, and technical variables. So what the outcome? It's one of the largest studies with more than 12,000 healthy adults. And they found that 44 specific bacterial species are consistently associated with estimated GFR, either in a positive or a negative way. And 51% of GFR variants are explained by changes in gut-derived metabolites. They are estimated around 1,010. And this again, far exceeded the clinical predictors like age, sex, cardiovascular risk, which explained only 14%. The metabolome panel, which looked at 1,010 metabolites, explained around 51%. And the gut microbiome alone explained almost half of the established clinical predictors of progression of CKD. So, all the harmfully associated. So, around only out of the 44, only 5 were positively associated, and the rest 39 was mostly negatively associated. And the gut microbiome fingerprint here was predominantly then this for the out of these 4 is very significantly associated with protective with a protective value. So again, the another thing they established was there are 2 metabolic pathways actually related to the progression of chronic kidney disease. One is from the carnitine metabolism, the other is from the histidine metabolism. So one is dietary carnitine, especially which used from and choline, which lead to bacterial conversion, was converted to trimethylamine N oxide, which is linked to inflammation and oxidative stress. And histidine metabolism, that's dietary histidine and bacterial conversion of this to imidazole propionate, again was previously implicated in kidney injury. So they bypass the gut, entering the systemic circulation and create a vicious cycle of oxidative stress in the kidney. So, and the conclusions they tell there is the possibility of an early biomarker tracking, especially monitoring circulating gut metabolites, an early warning system for EGFR decline, utilize the protective power of SCFA producing bacteria, the short chain fatty acid producing bacteria, and fostering those fermentation pathways to protect the kidney environment before CKD develops, and limiting, especially targeted dietary modification, limiting specific substances like carnitine, histidine to starve the negative microbial pathways of their raw materials. So the gut-kidney interplay begins long before development of CKD, and modulating should offer a early, tractable, non-pharmacological target for protection of the kidney. To summarize, there is a path-breaking message happening in the understanding of the gut-kidney axis, and still we are in a very early stage. Although we know probiotics and prebiotics show promise in managing CKD, significant limitations regarding strain specificity and dosage remain. We need large prospective studies to identify true relationships of gut microbiome with kidney health. And still, what remains elusive is where we need a cold chain to present viable bacteria, whether spores is live, which source is preferred, and how is going to colonize and how long it will continue, the quality control and the variation of dosing in different patients, where one dose is sufficient for all, And the studies should have the clinically relevant endpoints are still to be standardized and the validity of the studies. Thank you for your patient hearing.